Hello and welcome to this Make a Medic presentation on anorexia nervosa. To start, anorexia nervosa is an eating disorder. It's characterized by restrictive eating and distortion of body image, which is often associated with a low weight and sometimes purging behaviors. And it has one of the highest mortalities of any mental illness due to the consequences of starvation and also suicide. Therefore, all clinicians need to be adept in managing these patients. So firstly, anorexia nervosa is defined as having a low body weight, typically BMI below 18.5, therefore underweight, or it can be associated with rapid weight loss, which acknowledges that some people may be from a higher starting weight but still acutely unwell. And similarly, in children and adolescents, they may present with failure to gain weight or falling off their growth trajectory. Secondly, people with anorexia nervosa typically show patterns to prevent restoration of their weight. So this could include things like purging behaviours such as self-induced vomiting, reducing their energy intake and restrictive eating, and behaviours to increase energy expenditure like excessive exercise. And this is typically also associated with a fear of gaining weight. Thirdly, we see a distortion of body image. The body weight or shape is often quite central to the person's feeling of self and the self-worth, and the person may perceive themselves as being a normal or high weight when actually they are underweight. And then beyond these diagnostic criteria, there are other features that are commonly seen in anorexia, and these can include disturbances in mood and cognition, changes in performance at school and work, disturbances in relationships, as well as physical symptoms associated with malnutrition and starvation. In these patients, it's important that we take a thorough psychiatric history, and that will start with a broad history looking at the person's pre-morbid personality, developmental history, any significant life events or triggers, and also their history of physical and mental illnesses, family history, social history, and drug and alcohol history. People with anorexia nervosa are most commonly diagnosed in their teenage years, and there's a higher incidence in women. However, there is emerging evidence of anorexia nervosa being prevalent in other genders and age groups. Some occupational or recreational activities are associated with eating disorders, and they can include professional sport, fashion, dance, and modelling. Secondly, we need to inquire about the symptoms of the eating disorder. So, for example, are they restricting their diet? And if so, is it specific food groups or generally? Some people may eat in secret or have rituals around meal times. Ask what they think of their weight and elicit whether the person perceives themselves accurately or are they preoccupied with body checks such as weighing themselves or photographs, and any compensatory behaviours such as exercise and purging, because these can be just as harmful as restricting their diet. And finally, we need to take an overall look at their mental state. Anorexia nervosa is sometimes associated with other psychiatric diagnoses and neurodevelopmental conditions, and also an increased risk of self-harm and suicide. So we need to do a full mental state examination, including risk assessment. In terms of mood, some people with anorexia nervosa feel low or struggle to regulate their mood. Thoughts can be preoccupied with food or with body image or negative self-talk, and observing behaviours may allude to co-presenting neurodivergence. We need to think about physical health in anyone with an eating disorder. So first of all, we're going to want to take a history and look for some symptoms that are associated with anorexia nervosa. They could include fatigue, acid reflux, syncope or pre-syncope, amenorrhea, reduced libido, and hair loss. In terms of examination, we'll want to get an up-to-date BMI on the person or use centile charts if they're under the age of 18. And there are other signs that we may look for. Some of these are red flags for a person being acutely unwell with an eating disorder, including bradycardia, particularly if they have a pulse below 50, hypothermia, blood pressure if they are hypotensive or having orthostatic hypotension, that is a red flag. We'll need to look at their hydration status, and we can also assess their muscle strength, for example using the sit-up, squat, stand test. We will also look for things like signs of self-injury which need to be inquired about. And then investigations. So in primary care, it may be that you don't perform any investigations. However, in an acute hospital setting, we would be considering blood tests, urinalysis, and ECG. The ECG, we're looking for bradycardia or a prolongation of the QT interval. Urinalysis may allude to kidney damage, and then there are a range of different things we may look for in blood tests, which are also detailed in the MEED Guidelines. In In terms of management, we must be aware that these patients can be medically unstable and appear deceptively well. The first thing to consider is any advice that we can give in general practice. So, for example, if a person is vomiting, they should avoid brushing their teeth immediately afterwards because that can lead to further damage of their teeth, and they should be rinsing with water or a non-acidic mouthwash. We can advise that laxatives actually do not reduce calorie absorption and therefore try to wean the patient off of these. We would advise to stop excessive exercise, although that may be easier said than done, and we'll want to provide appropriate contraceptive advice. Just because a person isn't having periods doesn't mean that they are necessarily protected from pregnancy. In terms of monitoring, so it may be that this is done in secondary care, depending how unwell the patient is, but if not, then they need at least annual reviews of their physical health in general practice, and this could include ECGs, blood tests, checking of BMI, depending on the person's current physical state. Specialist referral. This may be to specialist eating disorder services. It can also be thinking about their bone health, whether they need any referral. If they are an under 18, it may be a referral to paediatrics. So it's important to get specialist involvement when required. And then finally, consideration of whether inpatient care is necessary. If someone has red flags of eating disorders, it may be that they need to be admitted to an acute hospital, or if they are very unwell with their eating disorder, whether they need to be admitted to a psychiatric inpatient unit. In terms of psychiatric secondary care, the kinds of interventions that may be considered would be CBT for eating disorders, which is typically 40 sessions over 40 weeks. There's also the Maudsley Anorexia Nervosa treatment for adults, which is typically 20 sessions. There's also specialist supportive clinical management. So these are all options for adults with eating disorders, and in children, it may be that they also consider family therapy, which is the first line for children with anorexia nervosa. Thank you.